In both the cases, we can have ancillary studies possible like immunohistochemistry and cytogenetics, but I would like to mention that there is no role of FNSC. I mind you, sometimes orthopedic surgeons do this mistake of doing an FNSC and on that report they do surgery. But there is per se no role of FNSC in bone and soft tissue tumors. This is the diagnostic algorithm that I have made. So this is adult with 40 years old with musculoskeletal. This one is not working. Sorry. So a 40-year-old gentleman with musculoskeletal pain, as I already mentioned, we have to think in line of myeloma or metastasis. So we'll do a radiology in terms of X-ray and MRI with adjacent joints. Then we'll do a metastatic workup first, like a CT chest, abdomen, and pelvis, or a PET CT scan and myeloma workup. If it turns out myeloma positive, we'll refer to medical oncologist. Other than that, if turned out to be a primary carcinoma, and we can do, if there is a lesion in like an extremity, like a proximal femur, that has a chance of pathological fracture. So we do a fixation or excision on the, depending upon the primary as well as the tumor burden, and then we'll refer to radiation oncologist or medical oncologist. Sometimes even more than 40 years old, sometimes you get primary bone tumors. So we'll do biopsy for that individual cases. So I would like to highlight that today is 4 February. It is the World Cancer Day. So coincidentally, we are here for musculoskeletal pre-conference. So the theme of the our Cancer Day is closing the care gap. So right now we are doing that. I think we are making this awareness program, and this is Dr. Pankaj with me, and he came to my alma mater GCRI last year. So yesterday I came to know that Shah Rukh Khan is so famous here, said that I want to that awareness regarding musculoskeletal tumors should be like this. Thank you. This is where I work in Surat. So Surat is the one of the it is the #1 cleanest city of India. I would just like to highlight, and it is the biggest trade for diamond and textile industry. This is where I work, a new civil hospital. I have honorary attachment there and a medical college in Smimer. And this is my small hospital, 10-bedded hospital. This is my operation theater setup. Thank you. Thank you all.
Thank you, Dr. Rahul. We are happy to inform you that Honorable President of Bangladesh Orthopedic Society, Professor Dr. Munam Hussain sir is present here. Welcome, sir, from our organizing committee of musculoskeletal tumor. Thank you, sir. Now our next speaker, Professor Dr. Abhijit Salanke, please. Sure.
Do you need the pointer?
It's okay.
No, it will change the slides only. If you need the pointer, you have to.
Yes, I'll try.
You have to laser pointer from there. Sorry. Okay, sir.
One more thing, please, time is allowed for 10 minutes, so should be cautious about the time, please, sir.
Okay. So, good morning, respected teachers, friends and seniors. So, my topic of presentation is radiology in bone tumors, and radiology is more than 100 years old investigation. Still, it's most important for diagnosis any bone tumors. So, the friendship between the two countries is of more than 50 years now, and we want to extend this friendship more so that the trainees from here can come to India, and from India the trainees can come here to learn, because this is an excellent setup of ortho.
The final thing is a follow-up or the pathology joint clinic if it is required. So collection, Rahul has already covered. These are the things, these are the instruments, or these are the things that we need to do a core needle biopsy. And this is the type of a specimen we can get. Like you can get a different kind of a specimen based on the scenario. Like suppose you have a giant cell tumor which is very lytic, very necrotic. You can get a specimen like this which is a very necrotic tissue. But if you have a solid tumor, you can get a good course, and you can get a small course if you have a big soft tissue component. So basic thing is, like when you are collecting in a lytic or a lytic sclerotic tumors, you have to heparinize your bowl. Okay, what we do is we take a small bowl of a saline and put 1 or 2 drops of heparin in that. So that will prevent the like a blood to coagulate and will keep your tissue separate. And then as Rahul has shown, you can filter that. But if you get good course like I have shown on the left, then you need not heparinize your saline. But it is always a good habit to heparinize your syringe, the Jamshidi needle, your syringe in which you are going to aspirate, as well as the bowl or the saline where you are collecting. Otherwise, your biopsy will be mixed completely with the blood, and the pathologist will find a lot of difficulty in identifying the small tissue. And that is especially true for a simple bone cyst or for an aneurysmal bone cyst, where the lesion is completely blood-filled in ABC, and you get only very small membrane of the tissue. So it is always a good habit to heparinize your system, your needle, as well as heparinize your sample collection area where the bowl, so that you don't get a blood clot. And even if you do not trust your pathologist, the rule is, and Rahul has clearly mentioned, never divide the tissue for sending to two different labs. So first, let one pathologist review your full specimen, and if you are not happy with the report, you can send the slide blocks to the other pathologist. Why we emphasize on this is because sarcomas are heterogeneous. So they will not be the same in the full area. So suppose you put a needle in the sarcoma, and we always say to take multiple cores from a different area inside the tumor. But suppose in one area the tumor looks low grade, the other area tumor looks high grade. You divide your specimen. One pathologist will give you a low grade tumor, the other will give you a high grade tumor. Actually both are correct. The problem is with you, that you have divided the sample. So never do that. So sarcoma, it is always good that you send all the sample to one pathologist. And this is like one of my senior pathologists always used to say, excuse me, here, this AC can you switch off please? It's very cold here. So one of my senior pathologists always used to say that it is like a jigsaw puzzle. We must have solved the jigsaw puzzles where we fix multiple pieces to find a common final picture. Okay, so the sarcoma diagnosis is like that. Your history, your radiographs, your pathology should match. If it is not matching by your first pathologist, then you can get it reviewed. So it is always like you should have to solve a jigsaw puzzle where all the pieces should match. If it is not matching, get a review with your other pathologist. Second is the request form. So this is our standard request form in Tata Memorial Hospital. I'll zoom it for you. So is this a correctly filled form? I have written the patient's age, patient name, the file number, date of biopsy, and the history. Is this a correct form that a pathologist wants? So this is not, because first thing is we are missing on the age, which is very important, as Dr. Salunke has mentioned, in having a various differential diagnosis. And second thing is this information is
as well, we do a repeat biopsy as well. So we are taking the sample out of it. So this is just a representative video ABC of humerus, showing how it's seen in IITV images. Now we are preparing we have taken the polydocanol, we are making a foam kind of a thing. So as to increase the volume of the sclerosant. And now we are injecting the sclerosant. Usually the measurement is like 1 ml cube volume. For that we'll take 1 ml of sclerosant. So probably 4 to 5 ml of sclerosant is good enough for a small lesions. So these are few cases of results of sclerotherapy. Sorry. So this is on presentation, a huge lesion after giving one sclero. After 1.5 year follow-up, this is beautifully solidified and patient is having no problem and she is able to do everything as per pre-surgery level. This is another example of aneurysmal bone cyst of proximal humerus treated with sclerotherapy, and this is the end result. Similarly, flat bones, that is very much helpful in acromion in the coracoid process, and it healed nicely. So the advantages of sclerotherapy, it is simple, negligible risk of open surgery, no scarring, daycare surgery, and effective in cases like pelvis and sacrum as well. And local control is comparable to intralesional curettage with better functional outcome. Coming to simple bone cyst, it is commonly seen in long bones. Most common site is proximal humerus and proximal femur. Most active during the growth spurts, and 2/3 presents with fracture. So in UBC cases, what we do is percutaneous trepanation of cyst, because cyst is said to be filled with inflammatory markers, mediators. So drainage of fluid itself help in healing of the cyst, and with that same time we'll inject methylprednisolone to help in relieve the inflammatory process. So this is an example of calcaneus simple bone cyst treated with trepanation of cyst along with methylprednisolone acetate injection, and this is how we can see how beautifully the cyst has healed. So this is also simple daycare procedure, and with that we have a good outcome. Coming to osteoidostoma, it is one of the commonest benign bony tumors commonly seen in males in second and third decades of life. So initially, long back, the classical treatment was to do a complete surgical excision of the nidus. So what was the difficulties faced? It was very much difficult. The nidus is of size of 5 mm to like 1 centimeter size. It is difficult to locate even under image guidance. Risk of damage in adjacent structures, as well as the post-operative complications, and the results was like scarring, the aesthetic problems were more. So we have evolved. Now we are doing CT guided radiofrequency ablations in our most of the cases. Few of cases we have done CT guided percutaneous drilling as well. So this is a RF machine, radiofrequency machine with its probe. This is just an example of osteoidostoma of distal femur with all sclerosis around and a small nidus in between. I have made a small video of osteoidostoma of distal tibia. So there is a nidus in posterolateral cortex. So we are doing under sequential CT, we are locating the tumor. Then with the help of the K-wires and under CT scan, we are locating the nidus. It should be bang on inside the nidus to have the best result. Then we are doing the sequential drilling of the outer cortex. This is the sequential over drilling of the outer cortex. Now we have injected the Jamshedi, and this is the Jamshedi needle, and this is the RF probe. This is the final checking of the placement of the RF probe in all three views. This is our radio frequency machine. We'll be doing the ablation for around 10 minutes at 90 degrees Celsius temperature. This is the post RF image to confirm the ablation of nidus, and our track can be seen in that way. So this is also simple day care procedure. Generally we do under spinal anesthesia, and sometimes we keep our patients for overnight, and this is an with a success rate of, I can say, 97-98%. So this is our standard treatment for osteoid osteoma. Thank you.
लैपटॉप निकाल देना लैपटॉप निकाल
Thank you, Rahul, for your nice presentation. Here, presents Professor Abdullah Rizvi sir, also presents Professor Mainuddin Ahmed sir. We are welcome in our conference, and also here presents Professor Dr. Shakil Akhtar sir. Thank you, sir, for your presence here. And here presents another one, Mr. Shandip Singh Shahani, Head Sales and Marketing, Head International Sales and Marketing, Excel Ortho Life Systems Private Limited, India, our scientific partner. Thank you. And now inviting Dr. Manish Pudi sir for presentation.
So a little challenging talk that Dr. Pankaj has given me to cover in 10 minutes to discuss principles as well as role of zoledonic acid as well as denosumab in giant cell tumor. Giant cell tumor per se is actually a 30 minutes lecture. I'll try to cover whatever I can. I might, and I'm sorry that if I extend time for by a few minutes. So for people who want to learn more about bone tumors, we are hosting our national conference, IMSOS, Indian Musculo-skeletal Oncology Society in Chandigarh. I am the scientific chair for that, and also I am the treasurer for the society. So for those who are interested, they can come and join us in Chandigarh from 8th to 10th of March. So as far as the treatment of giant cell tumor, the principles goes, first thing I think we should start with the staging. This is a very old staging given by Kempenaki et al., where we divide GCT into 3 groups. Basically, it does not call it like a more aggressive tumor. It depends upon when you pick a GCT. If you pick a GCT earlier in the due course, you will find a Kempenaki stage 1. But if you pick it a year later, you might get the same tumor as a Kempenaki stage 3. So a Kempenaki stage 3 does not mean a very aggressive tumor. That is what we should know. So basically, we can treat a Kempenaki 3 on the same principles as Kempenaki 1 if it is possible. So as far as the management option goes, we have these treatment options for GCT. One is the most commonly done procedure, which is a curettage. Then we can resect certain tumors. Then earlier we were using bisphosphonates. Now we more or less have shifted to denosumab. Sometimes we use for unresectable GCTs, we use embolizations or radiotherapy. So I think our focus of talk will be on curettage and role of adjuvants. Curettage was introduced by Bloodgood in 1912, and basically this is a very old paper of 1980s by Ward et al., which shows that the intralesional curettage with high speed burring is actually adequate in most of the giant cell tumors, and wide resection is required only when the bone salvageability is impractical. So we do wide excision in a GCT when more than 50% of the cortex of condyle is destroyed, or there is more than 80% of cross-sectional bone loss, or there is more than 50% of the articular surface of the condyle which is destroyed, or there is an extensive soft tissue contamination like I have shown in the picture on the side. Otherwise, you can curate most of the GCTs. So these are the other data which suggest that the curettage is effective in giant cell tumors, whether you use adjuvant or not, and the recurrence rate is in between 10 to 30%. Coming to the role of adjuvants in giant cell tumor, these are the commonly used adjuvants that we use in a GCT, most commonly the bone cement, then is phenol, then cryotherapy, argon laser and hydrogen peroxide. Actually till date, most of the people are confused whether to use adjuvants or not. That is the first question. And if you are using, what to use and how to use. So this is a very good data by Balke et al. Of 214 cases where they have compared 3 adjuvants. One is a burr, second is a cement and third is a hydrogen peroxide. And they divided actually tumors into different groups. The first group is they have done a curettage without anything. Second is with burring, then with cement and burring, and so far so on. So they kept adding another thing and identified the recurrence rates. And actually what they found out is the curettage without anything leads to almost 30 times higher recurrence rate than the best treatment group, which includes cementing as well as burring with hydrogen peroxide. And second thing is bone cement alone can reduce the recurrence rate by a factor of 8.2, while the addition of high-speed burring further reduces the recurrence rate by a factor of 3.9, which increases further if you add hydrogen peroxide. So basically, likelihood of a recurrence after curettage and cementing was 4 times higher than the same procedure with additional burring. So they recommended burring as a standard of treatment. So there is no confusion. When you are doing a curettage, the burring is a standard of care. You cannot do a curettage of a giant cell tumor without doing using a high-speed burr. By high-speed burr, I mean not putting on a drill. It should be on a high-speed system with a revolution of more than 60,000 per minute. So there is nothing below is a high-speed burr, and burring is a standard of treatment for a GCT curettage. So you cannot avoid burring. And hydrogen peroxide seems to have an additional effect compared to that of phenol, although it did not reach statistical significance. These were the conclusions from this paper. Then there were some papers where they suggested that phenol is very useful. This was a paper in 1999 by Durr et al., where they have used phenol in certain groups. Their conclusion was in curettage with phenol group, the recurrence rate was much lesser as compared to without phenol group. As you can see, 9% versus 43%, and they recommended phenol as a regular treatment. But the other data on the phenol 2 years down the line by Tribe et al. Showed no benefit of using phenol in giant cell tumor when you are using a high-speed burr. So then there was a meta-analysis which compared using of burring with other adjuvants, which included these 3 papers which I have shown. Along with that, they have included 3 more papers, and they have checked actually the role of burring as well as the adjuvants, which is phenol. So a burring plus adjuvant group had 323 patients, while burring alone had 64 patients. And you can see the local recurrence rates. So they were comparable. So they also concluded that adjuvants is not helping. What is the most important thing is a burring. This is a very good meta-analysis. You can go through that. And the claim that adjuvants such as phenol or cement are necessary to reduce recurrence is not supported in the literature as demonstrated by this work. So basically, if you want to take home anything from this talk today, is if you are doing a curettage, burring is a must. Adjuvants rarely help, so you have to use the least toxic adjuvant which is available, which is hydrogen peroxide. That is what we usually follow in a curettage of giant cell tumor. Because most of the time you get a big Campanaki 3 JCTs, and phenol you can only put on the bone. You cannot do anything in the soft tissue. Okay, so hydrogen peroxide you can put easily in the wound, which we usually use for infections also, and that helps a lot. So a good burring with hydrogen peroxide is what gives us a very good local control rate. This another data on risk factor for recurrence in GCTs, and they actually also have concluded that the PMMA with phenol has a little better as compared to bone graft and phenol, but the most important thing was PMMA rather than phenol, and because they concluded that local phenol did not improve the recurrence-free survival for the patient treated with GCT or bone grafting. So coming to the other part of my talk, which is role of denosumab and zoledronic acid in GCT, we all know what is denosumab. It's a monoclonal antibody binds to rank ligand and inhibits osteoclast formation, survival and function. This is the schematic diagram how the denosumab works. So this was the first data on denosumab published in Lancet in 2010, where they used it for unresectable GCTs or aggressive GCTs which were otherwise recurrent. And they found that the response was very good. 86% of patients had a response with a denosumab, and from there we started using denosumab in almost all cases. But what we found is when we use a pre-operative denosumab in a case where you want to cure it, we actually publish our data, the recurrence rates have actually increased. Why? Because the denosumab causes a ossific rim, and when you are curating, you might not be curating that ossific ring, which you will do otherwise if it is not a pre-denosumab case. So a pre-denosumab, using a denosumab before curettage is almost we have stopped using. So then what is the role of denosumab in GCT? Is we use it before resection or for unresectable GCT. These are the only two indications. So why we should use it before resection is because large GCTs are very vascular, they abut neurovascular bundle and they are cystic. You can see a recurrent GCT, you can see the placement of neurovascular bundle in a 24 years female. So this case becomes very difficult to resect. First thing it is vascular. Second thing it is cystic, so you can open the tumor intraoperatively. Third thing there is a risk of neurovascular bundle injury. Similar case for a proximal tibia. So in pre-denosumab era, we were doing angioembolization to reduce the vascularity and reduce risk of complications. So there were a lot of publications of using embolizations before surgery in giant cell tumors. But how does denosumab help here? So once we have started using denosumab, there are a lot of histological data that denosumab cause increase in fibrosis, as well as it reduces the microvascular density. So when we use denosumab, we are reducing the vascularity, making the tumor more stiff, more easy to handle, reducing the contamination, reducing the risk of neurovascular bundle injury, and reducing the blood loss. So we resected this tumor. You can see the post-denosumab, it ossified, and then we can easily resect this tumor and put a prosthesis. And this is what the literature also says, that there is a short-term role of a pre-operative denosumab when you are using it before resection and not before curettage. This is our data from Tata Memorial Hospital, where we have used neoadjuvant denosumab in 16 patients to facilitate resection. Only one patient got a recurrence, and we concluded that osseous rims reduces the possibility of injury to neurovascular bundle and facilitates intraoperative manipulation and reduces contamination. So this is how sometimes you get the rim. And same was the data from Italian group, where also they have concluded that there is a role of limited use of denosumab before a resection. So whenever a segmental resection is thought to be indicated at diagnosis, denosumab may be considered in neoadjuvant setting, but not when we are doing a curettage. Only 2 slides about role of zoledronic acid in giant cell tumor. So since the time we are having a denosumab, we rarely use zoledronic acid, but before that we were using zoledronic acid in giant cell tumor, in neoadjuvant setting, in adjuvant setting, in metastatic setting, as well as in unresectable settings. So there is some literature which supports that bisphosphonate for aggressive primary, recurrent and metastatic GCTs can help and can actually be controlled. This was the data of 25 patients where they used a Zol, and they found that Zol can be helpful in controlling the disease. But then there is another data that we suggest the adjuvant zoledronic acid is of no use. So this was a recurrence rate of a GCT after curettage and using an adjuvant Zol versus standard of care, and actually there was no difference in our recurrence, final recurrence rates. So per se, Zol, if you have denosumab, you don't need a Zol. If you do not have a denosumab, you can still try a zoledronic acid in a neoadjuvant setting. But most important role of zoledronic acid or denosumab is in unresectable giant cell tumors, which I am not covering here because of lack of time. But that is our policy, that we give doses like 4 loading dose of denosumab with angioembolizations for sacral or spinal GCTs which we cannot resect or cannot operate, and we continue managing them only with zoledronic acid or a denosumab and embolizations and do not operate them. And we get a 70% control rate. So we published that paper. You can go through the literature, GCT spine and sacrum by Dr. Ajay Puri et al. We published that data and we get a almost 70% control rate using denosumab with embolizations in unresectable giant cell tumors. Thank you very much.
Thank you, Dr. Banish sir, for your excellent presentation. Now it is type of question answer session. Please, dear participant, any question, please.
Directly. We just, no dilution. We just make a form, kind of, and increase the volume and use directly. After that, yes, for normal saline, yes.
One question.
Yes, sir.
So you say in case of ABC, you do biopsy first, then you go for sclerotherapy.
Not at the same time.
Not at the same time.
No, sir.
In two settings.
Yes, sir. Because I have already shown you one case that looking like an ABC turned out to be a telangiectatic osteosarcoma. Okay. So we have to be confirmed diagnosis first. So it is a two-stage thing. We explain the patients and they usually agree.
Okay.
Yes.
How
Yes.
many injections do you normally require?
It varies, sir. Yes, sir. So, according to the landmark paper, so usually we wait for 3 months and we'll have a serial X-rays and we look for 3 things: whether there is a pain clinically, the size of the lesion increased or not, and there is a sclerosis or not. And there is a like less than 25%, 25 to 50%, 50 to 75%. According to that, there is a grading as well. So if we feel that out of these 3 parameters, the 2 is not doing well, we may repeat the injections after 3 months. And from 1 to 4, the maximum would be 4 injections. That is the standard of
It is a
care.
massive. Four injections in 3 months' time.
No, sir.
In
3 months, after 3 months, again after 3 months.
first,
Yes.
how many injections you give in the first session?
Sorry?
How many injections do you require in the beginning of this treatment?
Only 1 injection, sir.
Only one injection.
Yes.
Then wait
Then
for
we'll wait for 3 months.
3 months.
Yes, sir.
Okay. And this depending on the size of this lesion,
Yeah.
you decide the number of injections required in the first instance.
In the no, sir. After that, the sequential X-ray will see and will review again, and then we decide whether to give the second injection or not. Right, Manish, sir, you have to.
Say, recently I am treating a patient of ABC in the humerus.
Yeah.
The size is about, say, 3 centimeter by 2 centimeter. Is okay? It's reasonably big. Okay. I have used 1 injection protocol the first time, and also used after 3 weeks second injections. Okay. 1 injection for that lesion. Okay, now I am waiting. So do you need to give more injections?
Yeah. So, sir, the thing is, like ABC can present with a very small lesion from like a centimeter or 2 centimeter to huge lesions, which can be around 15 centimeters. So the challenge here is that you cannot inject more than 4 to 5 ml of polydocanol in one sitting, because it is toxic and it can embolize through the vessels and it can cause a serious reaction. So the problem is that you cannot inject more than 4 to 5 cc's. So now the question is how to manage that situation when you have huge ABCs. Okay, so first thing is that ABC per se, the cavity is empty. Okay, the lining is what you need to damage. Okay, sometimes even if you damage one part of a lining, the ossification starts from here and ultimately will completely fill the lesion. So even if you do not inject the full cavity, you just break the trabeculae, the ossification can cover the complete lesion. So that is what we have seen, and we published also our data on use of sclerotherapy in ABC. Even the one injection is more than enough in almost 60% of patients. So you need not inject even a repeat injection, but for you need to wait a little longer. So usually we wait at least for 8 weeks or sometime 12 weeks, as Rahul said, to decide on a second injection. Because the ossification, as everyone knows, like we know the bone healing, the callus takes 3 months to appear, the bone takes 3 months to form. So it's a slow process. Initially the fibrosis happens, then the osteoblast will lay bone over that. So you might not see anything in 3 weeks. So you might have to wait a little longer to see some ossification in the lesion. For that, ideal time is anywhere between 8 to 12 weeks. Suppose there is a big proximal humerus lesion and you have injected only the upper part of the lesion. In 3 months down the lane, you see that the upper part is ossified but the lower is not. Then going again after 3 months, you can inject another 4 cc in the lower part. And as Rahul has shown in his technique, you do frothing. Once you do frothing, you can actually make 4 cc into almost like 8 cc or 12 cc's, so that you can actually cover the more or less the complete lesion. So per se, do not inject more than 5 cc's. And a word of caution is here is, like many of the time the ABCs have one wall which is deficient. Especially the case which Rahul has shown, a coracoid ABC. So coracoid ABC is very dangerous because the vessels, the neurovascular bundle is right below it, and if your posterior wall is deficient, I will not put a sclerosant. Because if the sclerosant leaks around the nerves, it will cause a permanent damage of the nerve. So many of the time in pelvic ABCs, in tibia ABC, we put a dye, which is the radio-opaque dye. Just put that dye in the lesion, 1:4 dilution, standard iohexol. See that the dye is not leaking into soft tissue. If dye is not leaking into soft tissue, aspirate the dye back and inject your sclerosant. But if your dye is leaking in the soft tissue, then we actually do not do a sclerotherapy. Then you can just do a curopsy. Use a curette and just break all the trabeculae and pray for healing. But don't do a curopsy if your sclerosant, if that your dye is leaking, because that can cause a permanent damage to the soft tissue. So that is how we manage ABC. Yeah.
Okay, thank you.
Yeah.
What is the dose of denosumab in case of GCT? Whether do you use in GCT? Do you use it in the day 1, day 8, day 15, and day 1 month? After
Yeah.
the 1 month, only the 4 doses for denosumab, 120 milligram subcutaneously.
Yeah, so over the years, we have become wiser in using denosumab. So earlier, we started with the protocol that you are saying, 1, 8, 15, and 28. Now, we are not using denosumab to facilitate a curettage. Okay. And what happened is, if you give a lot of dose of denosumab, the tumor becomes very strong, very ossific. So in that, the curettage becomes almost impossible, and we publish our result that the recurrence rate was 40%. So very rarely, if you use a denosumab to facilitate a curettage, you give only 2 doses, 1 and 15, and operate early. Operate at 6 weeks down the line, because so that you are not giving tumor much time to form an ossific rim. Okay, but we usually do not use that. So the indications of denosumab comes in only 2 settings. One is unresectable GCT, where you combine it with angioembolization. There you give 4 doses, 1, 8, 15, and 28, and then give monthly denosumab till the time your embolization shows a no tumor blush. So that is how we manage. Like suppose a GCT spine and sacrum comes to me, I give 1, 8, 15, and 28 denosumab, and first embolization will be at 6 to 8 weeks from the day 1. Okay. And we'll keep doing embolization at 6 to 8 weekly interval and keep giving monthly denosumab. And suppose our second embolization shows no tumor blush, we give 1 more denosumab and then stop. But then it will be monthly denosumab only, and then we don't give anything else. For GCT to facilitate resection, suppose a large GCT of a proximal tibia comes, you have decided it cannot be curated, it needs resection. So in that case, 2 doses are enough, 1 and 15. But you need to wait a little longer for the ossification to happen. That will take almost 2 months. So wait for 6 weeks from the last dose before you operate. So basically you need to tailor made according to the situation. It is not a one fixed way that you will use a denosumab in a giant cell tumor. Yeah, definitely. First thing is, so before giving denosumab, all patients should get a dental clearance. Dental clearance from the dental department, the teeth department, because denosumab can cause osteonecrosis of jaw if there is an active caries. So before giving any denosumab, first thing is you need to refer to your dentist, get your dental clearance done. If the dentist say that the teeth are infected, get the tooth extracted, wait for 6 weeks before you start your denosumab. Okay. Second thing is you need to check the before denosumab your calcium levels and supplement oral calcium during the phase of denosumab and 3 months after you finish your denosumab, because it can cause a shift of the blood calcium to the bone and patient can land up in a hypocalcemia. Okay, so a calcium level is mandatory as well as a dental clearance before denosumab.
Sir, I have a question. The recent WHO classification of bone tumor stated giant cell tumor and aneurysmal bone cyst as intermediate grade.
Yes.
Not benign, not malignant, in intermediate. But all the speaker presented the GCT and aneurysmal bone cyst as benign.
Yeah.
So what is the basis, what is the key point to differentiate it's benign or intermediate type of bone tumor as GCT or aneurysmal bone cyst?
So basically this WHO classification of calling GCT as an intermediate tumor or an ABC as an intermediate tumor is mainly based on the clinical behavior. Okay. So like you have a tumor like enchondroma, you have a tumor like non-ossifying fibroma which will never metastasize in life. Okay. So those we call as the typically benign bone tumors, or an osteochondroma which will not metastasize. But even a benign giant cell tumor can show a benign lung metastasis. The lung metastasis will also remain benign. They might grow slowly, they might involute on itself, or they might keep increasing slowly, but it can show a lung metastasis. So 4% of recurrent GCTs can show a lung metastasis. So whenever you get a GCT recurrence, you always do a chest X-ray. Okay. Same for aneurysmal bone cyst, because sometimes aneurysmal bone cyst can also show some little more aggressive features. It will keep increasing very fast. And many of the aneurysmal bone cysts, we might have to do a resection also rather than only a curettage or a sclerotherapy. So like we are about to publish our ABC data where we actually have identified the indications of surgery where we are failing. So sclerotherapy, we have a failure rate of 10%. So 10% of ABC will not respond to sclero, will keep increasing on sclero, behave in a very aggressive manner. So sometime even you have to resect that. Even we required a 2 4-quarter amputations for ABC. Biopsy proven ABC, they kept increasing so fast that the proximal humerus we have to do a 4-quarter amputation. The final report was still ABC. So that is why they have been classified as intermediate grade tumor and not purely benign tumors.
Thank you.
So basically you need to understand how the denosumab acts. I skipped that slide to save some time, but denosumab acts on the stromal cells of GCT, not on the osteoclast. Okay. And it reduces the activity of stromal as well as then secondary the osteoclastic activity. But when you curate the GCT, there are no cells left. So you have already curated it or you have already resected it. Denosumab is not going to work. It cannot work on the normal tissue. It will only risk the fractures, post-denosumab fractures. So no role of denosumab in adjuvant settings. Okay.
Thank you, Dr. Rahul and Dr. Manish sir. I think there is no more questions. Already we are late. I think session should be continue with tea. Our attendants will serve the tea. So we will start the third session. Yeah. So the first speaker of third session is Dr. Rahul Parmar. Please, Dr. Rahul.
Excuse me. Laptop. Acha, you have to connect me. Excuse me. So, I am going to present principles of treatment of primary malignant bone and soft tissue tumors. So, I think I have a lot to cover in 10 minutes, and this is as such like two separate lectures for that. So, I have tried to cover the maximum for your benefit. So, begin with introduction. Primary bone tumors are rare malignancies. They account for less than 0.2% of all cancers. So, most common is already discussed, osteosarcoma like 35%, chondrosarcoma 30%, Ewing's 16%. The most common bone tumors that are secondary bone tumors metastasizing from another primaries. But yet they cause significant cancer morbidity and mortality among the young people. It is the sixth most common neoplasm in children and third most common in adolescents and young adults. So this is a slide showing bone sarcoma skeletal locations. The osteosarcoma is commonly seen in distal femoral lesions and around the knee. And chondrosarcoma is seen in flat bones like pelvis, spine, and proximal femur and proximal humerus. Ewing sarcoma is seen in 40% cases in lower extremity, and as well as 26, I mean almost 40% in flat bones like pelvis and chest wall. Chordoma has a predilection for skull base and sacrum. There are few other sarcomas that has a tendency for particular location like clear cell chondrosarcoma femoral head, parosteal osteosarcoma posterior distal femur cortex, periosteal osteosarcoma anterior tibial shaft, adamantinoma in tibia and fibula. So what is the pathology, pathophysiology as well as the biologic behavior? So sarcoma are heterogeneous mass. They form a solid mass that goes centrifugally, with the periphery being the least mature, that is also known as reactive zone or pseudocapsule, in contrast to benign tumors that have a true capsule. The high-grade sarcomas, they have poorly defined reactive zones and that may be locally invaded by tumor, and which is known as satellite lesions. Sometimes these lesions break through the pseudocapsule as well and form skip metastasis within the same compartment. So this is the pictorial diagram showing a bone tumor with a reactive zone along with that satellite lesions and skip lesion in the same bone. Similarly, for the soft tissue sarcomas, a reactive zone and skip lesions. On histopathology, you can appreciate the skip lesion in the diaphysis of femur. Coming to the TNM staging of bone and soft tissue sarcoma, the important part is the T1, the tumor size is less than 8 centimeter, T2 more than 8 centimeter, and T3, that is a discontinuous in the primary bone, or we can say a skip lesion. Nodal metastasis is much lesser seen in sarcomas. And distant metastasis, M1 is lung, M1A, and M1B is bone or other distant sites. Coming to the grade, G1 is well differentiated, G2 moderately differentiated, G3 is poorly differentiated. According to that, we have staged them from 1A to 4B. Similarly, this is an NCCN guidelines for soft tissue sarcoma, TNM staging. For that, T1 is less than 5 centimeter dimension, T2 is greater than 5 but less than 10 centimeter, T3 is more than 10 and less than 15 centimeter. T4 is already more than 15 centimeters. For regional lymph nodes, N0, no regional lymph nodes, N1 is lymph node metastasis. M metastasis remains same, M1 distant metastasis. For histological grade of soft tissue sarcoma, we have a different classification known as FNC LCC grading system that covers the three things: tumor differentiation, whether it is a well differentiated or a poor differentiation, a mitotic count, and tumor necrosis. According to that, we classify soft tissue sarcoma. Coming to management principle, it is not a single person job. It is a multidisciplinary team that requires a tumor board. We have surgical specialists like our orthopedic surgeons. We have surgical oncologists, thoracic surgeons when we need a lung metastatectomy. Then we have medical specialists, medical oncologists, radiation oncologists, and nuclear physician, as well as diagnostic specialists in pathology and diagnostic radiology. We do have adjunct members like vascular surgeon, plastic surgeon, and we also have take into consideration of the patient's psychiatric well-being as well as fertility preservation. So coming to surgical management, this is the classification of surgical procedure. The intralesional excision is within the tumor mass and removal of only portion of the tumor, and marginal excision is dissection plane through the pseudocapsule. These are both for the benign tumors. There is no role of first two procedures in sarcomas. Usually sarcoma is removed with wide en bloc excision, that removal of the entire tumor along with pseudocapsule and cuff of normal tissue. So this is the guideline for surgical resection of bone sarcoma. We prefer that major neurovascular bundle should be free. Wide resection of the affected bone with the normal muscle cuff in all directions. All previous biopsy and potentially contaminated tissue should be removed en bloc. And bone should be removed 3 to 4 centimeter beyond abnormal uptake as we confirm on MR. Adjacent joint and joint capsule should be resected. Similarly, guidelines for surgical resection for soft tissue sarcoma. The tissue should be removed en bloc along with a normal cuff of tissue, and biopsy tract with 3 centimeters of normal skin and subcutaneous tissues. Margin surrounding the surgical wound should be marked with metallic staples for radiation oncologists to see the potentially area for the radiation. Reconstruction of defect should include local muscle transfer to protect the exposed bone as well as neovascular bundles. And all day space should be closed adequately and drain should be present to prevent the hematoma formation. So coming to a successful limb salvage surgery, we should consider 3 phases of that is resection of tumor, then the reconstruction, and finally is the muscle transfer to have the good functional outcome. So resection should follow as I already mentioned, the principle. According to that, we do the surgery, because local recurrence we should be consider that for the criteria of success and main determinant to remove how much amount of bone and soft tissue we are going to remove. Coming to skeletal reconstruction, after doing a sarcomatous resection, probably we are having a defect for around 15 to 20 centimeters. So how we are going to do a reconstruction? In cases of osteoarticular resection, our frequently used treatment is endoprostatic reconstruction, like we can see in a proximal femur resection and a distal femur resection. Joint arthrodesis that we use usually in select cases of extra-articular resections. Now this is, as even India we don't get a good allografts, so this technique, recycle autograft, is now what we use commonly. One is extracorporeal irradiation. We'll remove the tumorous bone we remove the soft tissue out of it, and we send the specimen for 50 gray radiation. And after the radiation, the tumor sterilized bone is reintroduced into the native bone and fixed with the plate. So this is an extracorporeal irradiation setup. Similarly, we are using cryotherapy. It uses in two fashions. One is pedicle cryotherapy. That in that case we do one osteotomy, and we dip the bone along with intra-op inside the operation theater in liquid nitrogen chamber. And the second is this is a free cryotherapy. We remove the bone, same as extracorporeal irradiation, and we dip into the liquid nitrogen and we fix it again. Commonly used for intergallery joint sparing resections. It is reproducible and cheaper, and as I mentioned, the strut allograft procurement is difficult. Coming to the last few slides, soft tissue and muscle transfer. Adequate motor reconstruction is necessary by regional transfer of the muscles. This is the proximal tibial resection, and we are this medial gastrocnemius flap to cover the defect as well as the cover the implant, so that the risk of infection and flap necrosis decreases. For soft tissue sarcoma, I would just like to say it is the most commonly done procedure, what we call as OOPS surgical excision. Consider it to be a benign tumor, you resect it out, and final histopathology came as sarcoma. So we have to undergo again for the surgery, and we'll resect extra. This was a small lesion, but we have to remove the extra because now it is all contamination. We have to remove more tumor, and now the bone is also exposed. So it requires a plastic surgery as well. Similarly, in this gentleman's case, considered to be a benign tumor, and someone resected out, and we have to do a wide excision along with the skin cover, and we have to do a latissimus dorsi flap to cover it. Thank you.
Thank you, Dr. Rahul. Our next speaker is Dr. Abhijit sir. He has two presentations consequently. Please, sir.
After we have the session of radiology, pathology, benign bone tumors. So I'm quite audible. So mic is not required. So after session on what is approach to bone tumors, radiology, we have seen pathology, we have seen benign bone tumors. We move to malignant bone tumors. So what are principles of malignant bone tumors? We need to remove the tumor completely, get good functional outcome. So principle of malignant bone tumor is to remove the tumor completely, very properly, with good margins, get good reconstruction so that the patient can have good function. So life with or without limbs. So we try to save the limbs if possible. So we try to save the limb of the patient if possible. If not possible, still the patient can have good life. So this is a small video of few of our patients and none of other patients. So never give up in sarcoma surgeries. So small child with very small hand, still he is able to do all his activities. Not a tumor case, but still a patient with no limbs. This is our patient. Limb was cut. We had put a myoelectric hand, a special electrical hand, which was developed, and he is able to back his work. He is himself an engineer driving back. Then we have cases of rotation plasty, means you cut the limb of the patient, turn the leg by 180 degrees, put it, the ankle works as a knee joint for this patient. So there can be a life with or without legs. So that is main purpose of this talk. So malignant bone tumor, you do surgery by two ways. One is limb salvage, remove the bone, put a joint, put a prosthesis. You can use patient's own bone, that can be done. Second option is amputation or a modified amputation. So these are the protocols what we follow. Go to X-ray, MRI, biopsy, chemotherapy, do surgery, again give chemotherapy, that is adjuvant chemotherapy. Then again take the patient for regular follow-up. So that is required, a long-term follow-up is required. So chemotherapy is given in osteosarcoma and Ewing sarcoma. It kills the tumor cells. Chemo before surgery is neoadjuvant. After surgery is called adjuvant chemo. And these are the principles. You do wide resection. You don't have to see the tumor. So if you are seeing the tumor, means you are violating the planes. So like eating an apple or a banana, you have its covering, and beyond the covering there is a plastic covering. So the tumor is removed in that way. A banana with its natural covering and a plastic covering around it. So in that principle you do tumor surgery. So what is rotation plasty? We will see example. So here is the tumor, you remove it. Only save the artery, vein and nerve. So all other structures are removed. Turn the leg by 180 degrees. Attach the distal part or the upper part. So you are converting a above knee amputation into a below knee amputation. Fix it with a plate. So this is how it is done. Remove the tumor. Save the artery, vein and nerve. That is most important. So here we can appreciate the leg is turned by 180 degrees and your artery, vein and nerves are saved. And attach this part to this part. So your ankle works as a new knee joint for the patient. So this is how the leg looks. Cosmetically it's not that great surgery, but functionally it's excellent surgery. So this is the child, remove his prosthesis. He will always require a prosthesis. Similarly, we have attached elbow to shoulder for few of our patients. Still they are having good function. The elbow is attached to the shoulder joint. So we can appreciate here the ankle he is working. So this is simple animation. Remove this tumor. Save artery, vein and nerve. Turn the leg by 180 degrees. Attach it here in upper part. Your ankle works as a new knee joint. So can be done for pediatric patient, can be done for adults also. So this is how the child looks. Cosmetically bit bad, we have done few modifications in this surgery. So that can be done. So then next is Krukenberg surgery. You remove the tumor. The two arms works like a chopstick. So remove the tumor and these two arms looks like chopstick. Again an alternative to myoelectric hand, because myoelectric hand is a costly option. This is a good option. Remove the tumor and it works like a chopstick. The patient flexes his elbow and it works like a chopstick. Next we go to limb salvage surgery. Remove the tumor around the joint. So you can replace whole of the femur, whole of the tibia, whole of the humerus. All parts can be replaced. So here we are using a megaprosthesis, means replacing epiphysis, metaphysis, diaphysis. Remove the tumor, put a joint. Remove the tumor and you can put the other bone. Here radius is removed and we have fixed the ulna to the metacarpals, centralization. So this is the patient. Remove the radius tumor and you have fixed it, and this was the function. Remove the tumor, you can use adjacent ulna. Patient's pronation, supination is maintained. Ulna centralization, ulna translocation, both can be done. Next we go to humerus. You can remove proximal humerus, distal humerus or total humerus. That can be replaced. So here we have replaced proximal humerus, total humerus and an implant cement spacer. That can be used, a cost effective option. Put a plate, two plates and a cement spacer. That can be done for these patients. So again important, Tikoff-Lindbergh surgery, where you remove the scapula, part of the humerus and part of the clavicle. So removing the scapula completely with part of humerus and scapula. So this is the function of the patient. So remove the scapula. Use a mesh to attach the remaining part of humerus with the clavicle. So scapula is removed, clavicle is removed, and humerus is removed. Patient will have no shoulder movement, but good hand and wrist function is there. Next, you can do ECRT. What Dr. Rahul said, send the bone to radiotherapy or liquid nitrogen. That can be done for diaphyseal tumors. So this is how ECRT is done. Send the bone to radiotherapy, bring it back, or you can use vascular rise fibula. That can also be done. Example of ECRT, how it is performed. So tibial tumor, you save the knee joint, take a cut from here, take a cut from lower part, send the bone to radiotherapy. 30 minutes radiation is given 50 degrees. And bring back the bone again. Fix it at its original site with a plate and screws. So this is how the patient function after 5 years. Excellent movement, knee, ankle, all joints are saved. So the dead bone becomes alive in few years time. It unites in 6 to 9 months time and it gets completely vascularized after few years. So that is advantage of ECRT. Next we do pelvis surgeries, hemipelvectomy. When you remove the tumor, you can put a 3D printed implant, that can be done. Or you don't put anything, still the patient works well. So always a hip joint or acetabulum is not required. So you can do 3D planning, take your incisions, remove the tumor here, femoral head is there. This is the upper cut, nerve is there. You can use the mesh, Prolene mesh. So over the femoral head, attach the mesh, and to the remaining bones, you fix it. Patient will have a pseudo joint, and still patient can walk with or without support. So this is the patient having no acetabulum here, but still back to her life. So small video of this. So tumor involving the acetabulum, remove the tumor. So here chemotherapy was not required. This is the tumor. There is no acetabulum. The head is just floating. Fix with a mesh. This is how the patient looks. 2 big scars. Able to walk with the help of a walker. After 6 months, 1 year, you can remove the walker also. They can walk with a stick or without a support. So the take home message of first presentation is you can replace the bone with a bone. You can use patient's own bone, that can be available. You can use artificial bones like megaprosthesis, or you can do arthrodesis or a mobile joint. So 3 treatment options. One is mobile joint, second is immobile joint, third is amputation. In amputation, you can have a simple amputation or a modified amputation. So next we go to megaprosthesis. So again we know what is megaprosthesis. So megaprosthesis is a joint which replaces part of epiphysis, metaphysis and diaphysis. So 3 parts are replaced. In normal knee replacement or hip replacement, we replace only part of the bone, epiphysis. Metaphysis or diaphysis is not replaced. So this is a special joint where you replace epiphysis, metaphysis and diaphysis. So again we go by example of infection. So why these surgeries should be done at a specialized center. So a case of infected megaprosthesis involving humerus. So this is how the patient presented to us. So primary surgery done at our center. Patient lost to follow-up, came again back after 1 year. We said we will do debridement. He again ran away, again came after 6 months. So this is how he presented to us. 2 options here. One is 4/4 amputation or try to save this limb. So commonly seen across the globe, not India, it can be seen everywhere, that patient runs away in fear of cutting his limb. So it's a pouring pus. You can remove this implant just by pulling it in your OPD. So we thought that we can give a chance. So this is how we was taken in OT and what to do. So just we pulled the implant, it came out. We give good debridement, antibiotics were placed, beads were placed. So remove the implant, treat with antibiotics 4 weeks. Then we had put a cement spacer. So it's now nearly 5 years plus follow-up of this child, again back to his life. So this is the final functional outcome. So you can try to save the limb if it's possible. So you have option of replacing proximal femur, middle part of femur, distal femur, or a total femur, depending on your tumor. So a patient with osteosarcoma, treated with chemotherapy, good response, cut the bone from here, cut the bone from here, replace with the megaprosthesis. So this is an example of proximal femur megaprosthesis. So these patients will not have any hip joint capsule here. So you can put a mesh here to fix this part to the upper part of acetabulum. So this is how the patient is placed. Medial or lateral incision is given depending on your tumor. Remove the tumor completely, put the joint here. So small videos of distal femur. Surgical key steps. So in this case it was a lateral incision. Take the flaps, remove the tumor, neurovascular bundle is completely free. The tumor should be very well covered with good margins. This is how the neurovascular bundle looks posteriorly. Post-op X-ray and again the functional outcome. Then we can replace whole of the femur. So remove from proximal femur, middle part of femur and distal femur. Again a small video of this. So this is how the implant looks, total femur implant. You're replacing the proximal femur, middle part of femur and distal femur. So in afternoon we will have a sawbone workshop. So what are the steps of megaprosthesis that we will discuss together with all of you. And this is how it looks. In this case, the greater trochanter was saved. So patient had good abduction movement. So these are parts of megaprosthesis. Very important that you have a femoral component, middle component and lower component. So again very important to assemble all these parts on table. So we use modular type of joint. Another joint is a customized joint. So in few cases we can use it, in a pediatric cases that can be used. So example of tibia megaprosthesis. These patients will have knee extensor lag of 5 to 10 degrees. So here we can appreciate the extension is less because you are reattaching the patellar tendon. Then next important is expandable or growing joint. Useful in pediatric patients. So two options available. One is a joint with magnetic field. So you put the limb in magnetic coil and this part grows. Very costly, very few implant companies are manufacturing this magnetic coil joints. We are using a invasive type, means small screw mechanism is there. Turn the threads and the limb will grow. So we'll show small video of that. So in this case we removed complete femur and this is the growing part and there is a small screw mechanism. So take few turns and the limb will grow. So this is the growing part which will grow. So this is the Indian joint, what we are using. So this is a small video of expandable total femur. So someone thought it's a benign bone tumor. He had put nails inside the femur, unplanned sarcoma surgery. Response to chemo was good. So we removed the femur completely and replaced with the expandable total femur. She was a girl 8 years old when she presented to us. So remove the tumor completely, total femur. So this is a cut specimen, how it looked. And these are the parts. So it is based on CT scan of the patient. So give the CT scan design and this type of joint is prepared. So which is a growing joint. So this is how it is placed in hip joint. We had put a mesh here. And we'll show how it is grown, expanded. So every time you have to give a 1 centimeter incision. Call the patient every year, do scanogram and then the limb will grow. So here we can appreciate a small screwdriver. The screwdriver is placed here. This part will grow. So maximum expansion in this case was 6 centimeters available. So can be done only in kids where you anticipate less growth. Can't be done in too small kids. In that cases you can do rotation plasty. So we can appreciate that this part is growing. So every time give a small incision. This was the post-op X-ray. This small incision is required every time. You don't have to open the limb completely. So you have to plan your screws on medial or lateral based on your incision. So good amount of planning is required and Indian joint is there. So 2 slides. Next is expandable proximal tibia. We have seen total femur, now this is expandable proximal tibia. So this is the joint. This is the expanding mechanism, how it looks. You turn the threads, so you need to know it's clockwise or anti-clockwise before surgery, how it will grow. So Ewing sarcoma tibia, young girl, you plan the resection. This is how we do our skin marking. Remove the biopsy scar with the specimen. Spikes are placed, cut the bone, remove proximal tibia with good margins. These are the parts, you assemble it. So again, patient specific implant, it is of that size of the person only. This is a resected specimen, this is the growing joint. And you take the gastrocnemius flap here. One thing important to appreciate, attach the patellar tendon to the implant. So you attach the patellar tendon to the implant with the help of fiber wire, fiber tape, ET bond, or you can use gastrocnemius or other muscles also to cover it, because you always have to cover it completely. So this is how you cover it to form the extensor apparatus. So the implant is completely covered because it is a subcutaneous bone. So growth can be achieved in this case, again 6 centimeters growth was possible. So we have covered that joints, they can be done, you can replace whole of the humerus, femur or tibia, and high chances of infection are there, but patient will have good functional outcomes after these. So thank you very much.
Thank you, Abhishek sir. Our next speaker, Dr. Tushar Das. Please.
Thank you, Dr. Pankaj Mondal, to call me upon the stage. I am Dr. Tushar Dash, Assistant Professor Radiotherapy working in Medical Oncology Department of Syed Sarodi Medical College and Hospital. For the next 10 minutes, I will delivering my speech on the principles of chemotherapy in bone and soft tissue tumor. Respected chair, learned faculties and other dignified participants, come to the presentation. Surgical resection remains the mainstay of treatment in musculoskeletal tumors, but it is difficult to treat patient with certain high-grade tumor by surgery alone. Adjuvant modalities like chemotherapy and radiotherapy play an essential part in the integrated management of these patients. Now what is chemotherapy? Chemotherapy is the treatment of cancer with one or more cytotoxic antineoplastic drugs as part of standard regime. Treatments like radiation and surgery are considered local treatments as they usually target the cancer directly. Chemotherapy differs from surgery or radiotherapy in that almost always used as systemic therapy. Chemotherapy drugs used today either alone or in combination with other drugs or treatments. Now, goal of chemotherapy. In curative intent, though cure may be the goal, it doesn't always work out that way. Now, control to shrink the cancerous tumor and or stop the cancer from growing and spreading. And in palliation, at an advanced stage, drugs may be useful to relieve symptoms, control tumors, or to improve quality of life. Now types of chemotherapy. It is neoadjuvant chemotherapy, adjuvant chemotherapy, palliative therapy, and intraarterial therapy. In neoadjuvant therapy, it is used usually in before surgery or radiotherapy, kills micrometastasis, kills tumor emboli at the time of surgery, kills decreases the drug-resistant clones in micrometastasis, decrease tumor size, less chance of viable tumor spread. Disadvantages are high tumor burden, drug-resistant cells may metastasize, increased chance of systemic dissemination. In adjuvant chemotherapy, it is after surgery or radiotherapy, improved survival rate for patients, prevent recurrence, decreased bulk of the disease, and drug resistant. Disadvantages are as delay in systemic therapy, chance of micrometastasis, no preoperative vivo assay, spread of tumor by surgery may have occurred. In palliative chemotherapy, it is usually used in inoperable patients, poor general condition, advanced or metastatic stage, disease-free state may, for many months, improves the quality of life, destroys microscopic foci, decreases tumor size, short cyclical course decreases toxic effects, combination of drugs increases interval between drugs disease toxicity. Intraarterial chemotherapy, preoperative chemotherapy administered directly into the arterial supply of the tumor. This gives very high dose to chemotherapy to the tumor, but less to the rest of the body. So, how the chemotherapeutic drug acts? They impair mitosis, largely targets fastly dividing cells. Here, you can see the cell cycle, and in different phases, different chemotherapeutic drugs acts. To block different phases of cell cycle by different drugs, we use combination chemotherapy for effective tumor control. This is the basic principle of chemotherapy to the cancer cells. Common chemotherapeutic drugs used in bone and soft tissue tumor. Here it is alkylating agents, antimetabolites, vincoalkaloids, antibiotics, and miscellaneous. Common toxicities of chemotherapy drugs are, as you know, myelosuppression is the main toxicity, nausea, vomiting, mucositis, bladder toxicity, alopecia, and hand-foot syndrome. We also face the toxicities. Common sensitivity of bone sarcomas to the chemosensitivity to bone sarcomas, highly sensitive Ewing sarcoma, moderately sensitive myeloma, and relatively sensitive osteosarcoma. In osteosarcoma, low-grade tumor, primary tumor includes wide excision only. Chemotherapy is not typically recommended. In high-grade tumor, chemotherapy is warranted for all stages. For non-metastatic sarcoma, 2 to 3 cycle chemotherapy are typically given preoperatively, and 3 to 4 cycle chemotherapy are given postoperatively. Common chemotherapy protocols are COS 86 protocol, Scandinavian Sarcoma Group 14 protocol, Intergroup Study 0133 EOI protocol. Common drugs used in these protocols are methotrexate, cisplatin, doxorubicin, ifosfamide, and leucovorin. The second-line therapy for relapsed or refractory disease, we use docetaxel and gemcitabine. For localized unresectable osteosarcoma, radiation therapy can occasionally provide long-term local control. For localized resectable osteosarcoma, radiation therapy is used as adjuvant therapy only when there is microscopic or gross residual disease. Now come to the Ewing sarcoma. It is radiosensitive and chemosensitive, controlled by radiotherapy with adjuvant chemo, palliative whole lung irradiation for cough dyspnea due to lung metastasis. Nearly all patients have micrometastasis at diagnosis, so we need chemo. We all need chemo, typically spread via hematogenous route. In Ewing sarcoma, we usually use VAC protocol, followed by I protocol every 21 days for a total 17 cycle. In myeloma patients, aim of the treatment, alleviating symptoms, controlling advancements of disease. In solitary lesion, we can give aggressive RT, and disseminated lesion, we give systemic chemotherapy. If we plan for the patient for transplant in future, we generally avoid alkylator and nitrosourea drug. In primary therapy, we can give, if transplant candidate, we can give bortezomib, cyclophosphamide, dexamethasone protocol, and in non-transplant patient, we can give melphalan, prednisolone, and thalidomide. VAD regime is the alternative regime in this case. Thank you all. Sorry. Thank you all for the patient's hearing. Today is the World Cancer Day, and in this year, today is the World Cancer Day, and in this year, the theme is Close the Cancer Gap. Thank you all.
Thank you, Dr. Tushar. Thank you, your very nice presentation. Now, question answer session. Any question, please? Dear audience. If any question.
Do you have any process like, in GCT and distal radius, we are usually do translocation and centralization. So cannot we provide a process over here? So are you practicing, or do you have anything like that?
I think Abhijit sir had one or case of, we had made axillo distal radius customized processes, no? Yeah. Well, personally, I have not done that. Abhijit sir has made for one patient, and I think axillo know about it. So, But we are comfortable with ulnar translocation and wrist arthrodesis.
We are also doing it. Another question is, do you have anything alternative than bone cement as a spacer other than this? Because we are also using bone cement, but do you have anything other than bone cement?
For smaller lesions, we have now bone graft substitute known as GeneX.
Okay.
So GeneX is basically a calcium hydroxyapatite, but it is in a form of cement. So you do not have to remove it, and after a period of 1 year or down the line, it converts into a native bone for smaller lesions, because it comes in two quantities, 5 cc and 10 cc. That's it. For larger lesions, we don't have any substitute other than bone cement.
So I have another query about the mega processes, because our bones is natural bone.
Yeah.
So we have some about the weight of these bones and other things. It's naturally naturally settled.
Right.
But when they just maintain or making these mega processes, weight is a matter. So when we just put it in inside the body, how the patient customize with these things, the weight and other things, whether he can customize it very normally or it is like cumbersome to him or not.
No, sir, you will be amazed to see the results of few of the results that patient is able to cross legs, sit on the floor, can drive, can walk, can run.
My concern is about the weight of the processes.
Weight.
Weight.
Sir, it is similar, like even if in our joint replacement cases, we have metal.
Metal.
Now we are shifting towards COCR and titanium alloy. So I don't say it causes some weight and a patient has to be uncomfortable because of that thing.
So is when they are just made it customized or made it
all customization, I think it is
okay.
Yeah.
Okay. No, but when you just put something in a whole.
No, even sir, mega prosthesis, I mean, patient has never complained in that manner, right?
Because you have that experience. That's why I'm asking you.
Sir,
Thank you.
Thank you, sir.
Any question? Any other question? I think there is no more questions. We will continue go for another session. It is very interesting session, video presentation session regarding today's session. Hope you all will enjoy it. And our faculties, Dr. Rahul, Abhijit sir, and Manish sir, please for video presentation. Abhijit sir. Now Rahul also shortly.
I'll try to finish the master video.
This is Dr. Rahul. Hello. This is Dr. Rahul. He is ortho-onco surgeon. He is from Surat, but he has another character and another. I think he is especially another criteria. All the doctors usually we do surgery, but never even other character or other criteria. Just only one thing: surgery practice. This is one. But Rahul is extraordinary. He is Everest climber, and. So we want to see the video clip from.
Okay. Thank you, Dr. Pankaj. So I will be sharing my master video on pedicle cryotherapy for osteosarcoma of femur. So what is actually a cryotherapy? So I have kept these slides to have a brief introduction about cryotherapy. So this was a paper from Suchia group, and they have reconstruction using an autograft containing tumor treated with liquid nitrogen. So they had 28 patients, and it consists of tumor bone has to be removed, and it was freezed with liquid nitrogen for 20 minutes and thawing at room temperature for 15 minutes, and again thawing in distilled water for 10 to 15 minutes. So that liquid nitrogen, it has minus 196 degree temperature, and it kills all the tumor cells. So this was a landmark paper. From that, we have started using cryotherapy. Again, that group came with a pedicle frozen cryotherapy. So what is a pedicle cryotherapy? They were using free cryotherapy. I mean, they are doing osteotomy at two sites, removing the bone from the body and freezing in the liquid nitrogen chamber. Now they came up with a pedicle cryotherapy. So this is a lesion in proximal tibia. They cut at the proximal tibia, one osteotomy. Now they did a distal fibular osteotomy so that the leg can be arc of rotation 180 degree, and they froze into a liquid nitrogen containing chamber, and again fix the tumor bearing bone with the native bone. So there is only one single osteotomy. Advantage is only one single osteotomy has to unite. In free cases, we have to wait for the both osteotomy to unite. So this is the paper, the example of the paper only. This is the lesion in proximal humerus. They have taken osteotomy at this side and rotated the arm in this manner, 180 degree rotation, and fixed it with a nail. Similarly, a lesion in proximal femur, and they resected out the specimen, osteoarticular resection, and they did a 180 degree arc of rotation inside the container, liquid nitrogen, and fix it with a long stem bipolar. So coming to my case, this is a 30-year-old male, non-metastatic osteosarcoma, given a neoadjuvant chemotherapy with a good response, and we planned a limb salvage in terms of pedicle cryotherapy. Sorry. So this is the distal femur. Diaphysis is basically diaphyseal location, osteosarcoma of femur. Excuse me, anyone is there? This video is not working. It is not going into full screen.
Oh, okay. Oh, it has.
Some problem with it?
So which one is yours?
The last slide. Yeah, this one.
The RAM is lower RAM.
Okay. Master video medical card.
স্ক্রিন কি চলে গেছে নাকি?
You can try this side.
Which one?
Last slide.
ঠিক আছে আপনি
So this is the T1 weighted coronal image MRI showing lesion in diaphysis of femur with an extraosseous component. So we planned on the MRI whether when we are going to take the cut. It is 30 centimeter from joint line and tumor distance from knee joint line around 12 centimeter. This is how we plan. This is the biopsy tract we excise along with the tumor. Lateral approach to distal femur. Proximal osteotomy at 30 centimeter from joint line. This is the neurovascular bundle dissection, tumor freed from the neurovascular bundle. This is the sciatic nerve and popliteal vessels. I have marked the arrow. We are just checking the feasibility of whether I can able to rotate it 180 degree. We have to resect the extra soft tissue so that we are able to easily rotate the leg 180 degree. Now I am going to do in situ preparation for tumor debulking. This is on the, I have covered the primary area and I am doing it on a separate OT trolley so that the tumor, because I am opening the tumor right now, it does not get into our native area. So we take extra precautions to cover everything with a plastic sheet. Now I am removing the tumor for histopathological examination. Drill holes are made so that when liquid nitrogen goes inside the bone, it expands. So it may cause fracture as well. So we have made drill holes so that it doesn't get fractured. Now this is the container. I am checking again that my tumor is like on this margin. I have 3-4 centimeter extra as a margin as well. And I have covered with a neo drape so that the freezing effect of liquid nitrogen may not cause any damage to native tissues. So we have a separate team pouring liquid nitrogen around 30 liters at minus 196 degree temperature. So I am checking the level, whether it has adequate or not. So it is like this in the operation theater. Now I am going to dip the leg for around 20-25 minutes in this liquid nitrogen. Now we have to be careful that we don't damage any surrounding soft tissues, so that it has been covered with the neo drape and plastic sheets. Again, the surgeon and the assistant also be careful about this liquid nitrogen. It may cause kind of a frostbite as well. So once the level gets decreased, we again pour the liquid nitrogen to maintain the level. After that, this is the effect of liquid nitrogen. It causes ice crystalline crystals all around the bone. So we can appreciate that effect of cryo is there. This is the post cryo effect. As you can see, the ice crystals have been made. Now we are thawing at a room temperature for 15 minutes and warm normal saline wash for 15 minutes. So this is after thawing with normal saline, and we are fixing with 2 plates, one anterior and one long lateral distal femoral plate. And as I have discussed, muscle transfer and coverage is necessary for the function outcome as well. Double flat drain, final closure peak. This is the post-op X-ray. Only one osteotomy. You can appreciate these drill holes, as I already mentioned, to prevent the fracture. This is the 4 years outcome. He is disease free with an excellent outcome, with good hip and knee range of motion, and he is able to do everything as per his pre-op status. Thank you. Yes, sir. No, implant is there. We have to keep the implant there because the bone is basically inherently weak after doing this cryotherapy. Right. From pre-op MRI, I showed you the MRI planning as well. Proximal osteotomy I has marked as a 30 centimeter. Distally 12 centimeter I left from tumor, so that surrounding soft tissue.
Yes, sir.
Surrounding soft tissue, we basically see in the MR only. We have a good idea about which muscles are involved, like in this case, vastus lateralis was part of vastus lateralis was involved. So we plan from the MR itself that what muscles we are going to preserve, what muscles we are going to sacrifice with the tumor as a good margin all around, so that we don't enter into tumor itself. Because it is a pre-operative body. Nothing can be decided on table. Because I was shown that when I was opening the tumor, it was a good muscle all around. After that, I go inside the tumor, right? So it has a good muscle cover all around. Right. Thank you. That one, which one? You want me to show that also? Right now? Or whether they can show in the last? Huh? That would be better.
Dr. Abhijit sir, please.
We will be seeing 2-3 videos. One is ulna, one is radius, then one calcaneum, 2-3 small videos. So tumor involving the ulna, proximal ulna, what are the treatment options available? So proximal ulna, you need to remove the tumor. It is forming a joint with the elbow. So you are removing the olecranon and around 10 to 15 centimeters ulna. So what are the treatment options available? You can remove the bone completely, put a 3D printed ulna, that can be one option, a special implant. Second, you can put a fibula. Third, you can remove the tumor, just put the radius into the olecranon fossa. So we are removing the ulna and putting the radius into the olecranon fossa. So radiocapitular joint is formed. So tumor involving the ulna here, proximal ulna, osteosarcoma, which was resected. So before surgery, you do X-ray MRI, biopsy, metastatic workup was done. This was paraosteal osteosarcoma. So doesn't require chemotherapy before surgery. And if final histopath is de-differentiated, then only give chemotherapy. So you plan your resection, how much ulna you have to remove. So this is the biopsy scar. Make your skin incision, raise the skin flaps. Find the ulnar nerves. You save the ulnar nerve. In majority of cases it is saved. This is how the nerve is saved. Take the distal cut and remove the ulna completely with good margins. So in few of cases we have to cut the posterior interosseous nerve, but majority of cases it is saved. So this is how ulna is removed. Make holes into the radius and into the humerus. 0, 3, 6 and 9 o'clock we make holes. Put fiber wire or fiber tape. In this case ethibond was placed. Attach tricep to the radial head that we have attached. And the radial head will be in the olecranon fossa now. So this is how it looks. So you are putting the radius into olecranon. So patient will have limited movement, but still good function, no pronation, supination. Some degree of flexion is restricted, some extension is restricted. So your radial neck will be near the capitulum. So it is a radiocapitular joint, what you are creating. So again, we have done good number of cases and we are sending this for publication. And these patients we are having good follow-ups also. So this is how it looks. So this was around 5 years follow-up of this girl. So there is limitation of elbow extension we can appreciate. Good function, good flexion, good extension. And posteriorly it looks prominent. This is a subacute bone. If you want to put any implant, you require a flap. So that is bad thing. So this is one case of ulnar tumor. Then we go to a common tumor, giant cell tumor, which everyone operates. As an orthopedic surgeon, every orthopedic surgeon operates a giant cell tumor. So what are the key steps of curettage and an extended curettage? That we will see. So kid with lesion in radius, again biopsy done, giant cell tumor. So what are the steps of curettage here? So mark the incision. Take the flaps. So make the windows. Cut the, in giant cell tumor you have to make a door. Make a small hole first, then extend the size so that you can see 360 degree. Remove the tumor with a spoon. That will be a curettage. Then give wash. Use hydrogen peroxide. Use a burr. We use cautery also. In this case, bone graft were placed and closure was done. So this is how the incision was taken. So tourniquet was used in this case. So this is how you mark your window and make it bigger. So make holes with the help of K-wire. Use osteotome so that you can see the tumor completely 360 degree. So small window make into a door. That is important. So after that, remove. This is how the cavity looks. Take simple curette or a spoon. Remove the gross tumor. Then give good wash. You can use pulse lavage also in these cases. Take a burr. High speed burr is used. That is most important. Burr all the walls so that it is very smoothen. That is again an important step. So burr is most important to extend the curettage. So you can use mechanically a burr. You can use hydrogen peroxide as a chemical adjuvant. You can use phenol. You can use liquid nitrogen. You can use argon beam. So all things we have used. So here burr was used. After burr, the cavity looks this way. Then we are using phenol here as adjuvant. So rub all the walls with phenol and then add alcohol to it so that the phenol get washed. Because in body, phenol can't be metabolized. So absolute alcohol is used. After that, we use cautery. Here, a cautery burr with a ball point is used and make the temperature 100. So normally use 30 to 40 so that your walls are again burred and charred. And iliac crest blood was taken and mixed with that, and the cavity was closed again. So this was the resected specimen sent to the pathologist again. And case of soft tissue sarcoma, we'll see a video. So again, a case of soft tissue sarcoma or a big fungating lesion. In these cases, we resect this tumor and this will spill over normal area. So you need to cover it. So we put a gauze, mop, a IO-band around the tumor and then resect it. So this way we do. The fungating part is covered completely and with good margins remove it so that it again doesn't get spill. Vac can be applied, vacuum assisted closure. This is the margin, base of resection, which will be the closest. And artificial skin graft substitutes can be used here. That is also a good option. So this is the defect, how it looks. Try to close the edges. This is artificial skin graft substitute. So single layer was used. It is made from sheep's intestine, artificial skin graft substitute. So less chances of rejection. And this is how it looks finally. So case of fungating sarcoma to its closure. And the last case, use of megaprosthesis in a non-oncological cases. As an orthopedic surgeon, we can use megaprosthesis in non-oncological cases. So non-union case, this was a non-union. African patient, he was an African patient, came to India for surgery and multiple surgeries were performed. So after this, a cut was taken here, cut was taken here. And this is how it looked. So important thing was the canal size was very big here. So that we didn't anticipate. So learning lesson that you need to get the dimensions of this part also. Our implant went just inside it and we had to pack here with cement. So distal femur megaprosthesis can be used in non-oncological cases. Second case is by Rahul only. So he did. This was the patient and back on his legs. This was a case performed by Rahul, distal femur, shattered knee, bone loss. So no options available. Debridement was done, X-fix was applied, and after that he had put a megaprosthesis. So this was a defect, and this was a defect, a clean wound, and he had put a megaprosthesis. This was the mega prosthesis here, which was placed by him. And lastly, a case of proximal femur, again done by one of our fellows, Dr. Mayur Kamani. Again, a shattered bone here, he did. So he placed a proximal femur mega prosthesis. So are alternatives available? Yes, alternatives are available. But this was a case where he used a mega prosthesis in non-oncological cases. And you can attach the trochanter here. So again, patient will have good function. Attached with the fiber wire or fiber tip here. Thank you.
Not coming there. It is not coming here. Yeah. So in next 12 minutes, I'll be showing a curettage and cementing video for a giant cell tumor of lower end femur. Okay. So we'll be seeing the steps for the curettage as well as the important instruments that we need to do a curettage. Okay. So I'll start the video now. So this was actually presented in the Viro conference recently. I was not aware that I have to present it here again. No worries. So this was a 33-year-old female with a right distal femur giant cell tumor, and our plan was curettage and cementing. This was the X-rays. You can see a expansile lytic lesion in the lower end of femur, right, reaching up to the subchondral plate, Campanaki 3. These are the MRI imaging, although little dark, but you can actually still make out the lesion in the lower end of femur. And in the axials, you can see a soft tissue component around the tumor, which is predominantly on the anterolateral side. So these are the steps for a curettage. First is elevation of step, flaps and isolation of field. Then we do a gross curettage, then extend the cavity, use sharp curettes, then use burring, lavage, change of drapes and reconstruct. Going to the first step, which is elevation of flaps, you do a standard orthopedic incision, isolating the biopsy scar. Always try to remove the biopsy scar even if you are doing a curettage. So elevation is very important to reduce the surrounding contamination. So this is how we elevate. You can see the vastus medialis proximally, and you clip important feeders if required. And I am extending now posteriorly, as you can see. On your right is the proximal part, on your left is the distal part. I leave a little bit of vastus medialis over near the biopsy scar, and rest of the flaps I am elevating. So once you elevate, you have to open the joint distally. As you can see now, I am opening the capsule, and once you open the capsule, you can see the joint cartilage there. Once you do that, you pack superiorly and inferiorly with hydrogen soaked gauze pieces, so that the spillage will not cause a seeding of the tumor. Then you put self-retaining forceps both proximally as well as distally, so that your field remains isolated. And this finishes the first step, and then you move to the gross curettage. So measuring in the MRI, you know what was the size of the tumor, and the same length you mark here. It was 7 centimeters. So same 7 centimeter we mark here, and we open this much big window to access the tumor. In this case, because the bone was so soft and expanded, we are using only cautery to open the window. Otherwise, you can use a bone saw also to open a window. You incise in the pre-marked area. And once you incise all around, you can use a cocker or Alice to hold the tissue, and you can open the window. You can see a friable tumor below. And now the steps are very important, because you don't want to contaminate your surgical field by the tumor seedlings. So we always put a surrounding drapes so that nothing is contaminated, you use a simple blunt curette now to release the tumor from its wall. Use a spoon to take the tumor and keep putting in a bowl which is kept nearby. You can see that I have actually isolated the surrounding area so that the no instruments also goes back to the main trolley. You do a gross curettage by using even a standard curette which is available in the most orthopedic theaters. So once you finish the blunt curettage, you need to plan extending your cavity. But before that, just give a wash and have an idea about where all your cavities is expanding. So you can see proximally that the articular cartilage is exposed, and then we plan for an extension of cavity. Once we give a wash, now you know that that is the articular cartilage, but there is a surround overlap soft tissue which is still overhanging the window. So we convert from window to a door. You elevate it all around the borders. This is a very key step in a GCT curettage, that you expose the bone all around. Otherwise, your tumor residual. Sandeep, can we have a little less noise, please? Thank you. Yeah. Or otherwise, the surrounding area will remain contaminated. So you elevate all around, expose the bone. Now in the distal part also, in the posterior part, sorry, we'll again elevate. You can see that I am elevating with the cautery. You keep the contaminated area proximally and then elevate the rest of the flap. You can hold it with Alice or a Babcock and keep elevating, because these are the areas which will keep harboring the tumor cells. So once you do that, you excise this part of a soft tissue, and this completes your extension of the cavity before we proceed with the high speed burring. And as you can see, when I am excising, I can now see the bone on the posterior aspect. Okay. So this is the bone where I will be again elevating with the cautery, because I need to burr this part of the bone, otherwise my recurrence is going to start from this part. So you elevate, expose the bone ends posteriorly. You can see the joint which is partly opened posteriorly, but expose the bone ends proximally, distally, superiorly, inferiorly. Then you use your sharp curettes and assess. Now we use various kinds of Codman curettes which are available in multiple shapes. This is especially important around the joint cartilage where you cannot burr. You can see that the cartilage is exposed there. So I can only use a curette there, I cannot use a burr. Or if there is any soft tissue defect, there also I will use a sharp curette rather than using a burr there. Once I finish with my sharp curettes, I again give a wash before I start burring to have a final assessment before burring. Then this is, as I have told you in my presentation also, the high speed burring is the key step. Use the Midas Rex at 60,000. Start with the edge of the tumor, which is the wall of, which is the proximal or the inferior edge. Do the edge first, then you do the wall. You use a sequential burring. I prefer a round burr, but you can use an acorn tip also. Burrs are available in two shapes. So burr the edge, then go to the wall, and sequentially one wall, then the other wall, and the proximal part you do it last, because you don't want to open the marrow and contaminate your field by the marrow tissue or a marrow blood. And in between the burring, keep assessing your cavity. So we stop burring in between, we wash and keep assessing our cavities again. So see, we do a wash, see the part that we have already burred, that looks nice and clean. Then we move to the other part. Now I am moving to the posterior part. Same, I'll do the edge first and then I do the wall. If any doubt, nibble the edge a little bit so that the burring is smooth. I am doing a proximal edge, then we'll do the proximal wall. So it is always sequential so that you don't forget to burr any particular area. So once you finish the superior part, the inferior part, then you can do the burring towards the joint, and in that case you need to change your direction of the burr. So I am burring from distal to proximal now. Now I am burring from proximal to distal, and I am burring the subchondral bone which is there, which is still harboring the disease, but not around the cartilage. So do a good burring, keep washing so that you assess, and then finally you can burr the main cavity, deep cavity, as well as the proximal part. So once I have done that, now I am burring the deep cavity, and then I will open the marrow. Now I am opening the marrow so that there is no blood which came in between, and now it is allowed because you have to burr the full cavity. So the burring of the marrow or the proximal part we reserve for the last. Once you do that, give a good wash, see your cavity again. You can use a dental mirror also to assess your cavity, or you can use a light source. So once we finish the proximal part, I'll be showing how we use a dental mirror to assess any nooks and corner. So do a wash. This is a pulsatile lavage system that is compulsory also. There are two things which are compulsory. One is burring and second is a pulsatile lavage. So after a pulsatile lavage, you see a nice, good, clean cavity which is now not harboring most of the disease. So this is the cavity which is finally after the lavage. Then you dry it. And you can use a dental mirror to identify any nooks and corners which are left by the disease, or you can switch off the main OT lights and use a light source also to assess any disease which is left. In this case, I thought there was some doubtful disease proximally, so we burred in the light source. If you have to repeat burring, then you have to repeat a lavage, and before you proceed for reconstruction. So I repeated a burr. I can again cause the contamination, so I will again do a pulse lavage before I go ahead and use some adjuvants. I again measure also that I have burred 7 centimeters. I use a pulse lavage again, dry the cavity, then use hydrogen peroxide. Best way to use hydrogen is keep it there. Once you put hydrogen, you put a mops, close the wound and change the drapes. Keep the hydrogen for 8 to 10 minutes. In the meantime, you change your drapes, change your gloves so that your hydrogen gets adequate time. Then you change your drapes and finally move to the reconstruction of the defect. In this case, I preferred a cementing. So we used a plate to fix because there is a risk of fracture. We use a standard stainless steel plate and we fixed it with 2 screws proximally and 3 screws distally. Once you do that, you can fill the defect with a cement. So you have to actually bend the plate little bit so that it is not prominent. I have used a gel foam distally to reduce the thermal damage from the cement to the cartilage, and then you can start filling your defect with the bone cement. So once you fill the full defect, you can see a C-arm shot, and then you can get a final X-ray done. So this is the final X-ray picture. There is no leak. You can see a still lysis distally, which is of a gel foam, and rest looks good. The patient can start walking from day 1. So we allow a full weight bearing walking if you are using a cement for reconstruction from day 1. And usually our recurrence rates with this kind of a procedure is less than 5% in GCT. So we usually are able to control the disease. But main thing is the key steps are very important. Do not contaminate the field by the instruments. Be very careful. The instrument should not go back to the sister trolley. Isolate the field with a hydrogen soaked gauze before you start opening the tumor. Third important step is a burring. Fourth important step is the pulsatile lavage. Then the hydrogen peroxide. Let it act till the time you change your drapes. Okay, and then you do a reconstruction. With this, I think the relapse rate will be less. Thank you very much.
Sir, when will you remove the implant?
So we will never remove an implant. We will never. Even if we put a bone graft, we will not remove. Even if we put a cement, we will not going. Because see, such a big defect. If I remove an implant, it is going to fracture. So we don't remove unless we get a recurrence. Otherwise, the implant stays till the time the joint is not getting arthritic, and then we'll convert to a prosthesis. Yeah, so in this case, usually we prefer allografts. In this case, because the cartilage it was subchondral, cartilage was ping pong, so we need to support the cartilage with something which is strong. Otherwise, the cartilage keeps moving and that cause early arthritis. So we use allograft in almost 70% of GCTs, 30% we do cement. So I have shown you a case of cement, but we have a good tissue bank and we prefer allograft to preserve the bone stock as much as possible. So initially, sir, we were very worried about the infections and we used to continue antibiotics for 3 weeks. But now we rarely use antibiotics. Even when we are putting an allograft, we stop it next day morning. And our infection rate in GCTs are like, you can say, almost nil. I am not aware of any infection that we encounter in a curettage, even if we put an allograft or cement. But our all allograft that we use are irradiated, are all radiation sterilized. We don't use a directly frozen allograft. They are all irradiated allografts, and we do not find. Another key thing that you can do when you're using an allograft is wash it with a pulsatile lavage before putting into the body. What happens is that reduces the marrow elements from the allograft, and that reduces the lot of irritation or the allogenic tissue, because the marrow is the allogenic tissue. So when you have a femoral head, you wash it with a pulsatile lavage. The allograft will become much more cleaner, much reduced marrow elements, and that will reduce your post-operative infection rates also. That is what we regularly follow. So basically, from the cavity, where your cavity is extending, you need to put at least 2 screws proximally. 2 screws are more than enough. Okay, so you can choose accordingly. Distally you can put 2 or 3, but proximally 2 are more than enough. Yeah. You can, but it will be very costly. In India, we cannot afford that. So because 5 cc of synthetic bone is cost around 12-15,000. So you have a defect which is for 50 cc, 100 cc's. How will you fill that? It will be huge. So we have allografts. Otherwise, the cement is very cheap. So use 2 packets of cement, cost around 8,000 INR, and that is more than enough.
Sir, what is the result of autogenous fibular graft?
Autogenous?
Fibular graft.
So autogenous fibula is also limited by the amount that you can get and amount you can fill. Okay. So sometimes you have a defect which is contained. You just need to put few struts in that. In those scenarios, you can put an autogenous fibula. But this kind of a defect which is big, which is uncontained, the fibula will not help. Okay. So if you have a cavity wall which is most of the wall is intact, then you can put some struts inside. Very useful in proximal humerus. So autogenous fibula I use usually for proximal humerus, autogenous or allofibula. We have allofibula, so we use allofibula, but that you can use for proximal humerus. Second is some people use it for radius, which we don't prefer. So for radius also we prefer ulnar translocation, I think either as has been shown, or we use an iliac crest cortical for an arthrodis. But radius we always arthrodis. We don't do an arthroplasty with the fibula.
Thank you, sir.
No. We first fix and then put cement, because otherwise you get cracks in the cement. So we first fix. The only caveat here is like this, I have also burnt my fingers once, is when you put a big plate, sometimes you don't get a space to put the cement. So be very careful about your position of the plate before you finally fix it and before you mix your cement. Your finger should at least be able to go to push the cement towards the joint. Otherwise, your subchondral area will not get that adequate cement. So when you're putting a plate, keep some space for your finger to go. You can put a plate little more anteriorly or posteriorly, but have some space for you to push the cement. Yeah, so the tricks for burring is that if there's suppose I'm dealing with a medial condyle femur. So we burr usually 2 to 3 millimeter deep. So that is why it is sequential burring. You understand, okay, I have burred this wall, now 3 millimeter, now I'm not going to touch this wall again. Same for the posterior wall, same for the inferior wall. And suppose there is a defect there, then you don't burr. So before burring, after giving a wash, you assess your cavity. Identify the sites where you should not be burring. Okay, so usually you have a posterior defect, so don't burr that area. You use sharp curettes and clean that area. And to give hydrogen, that works. Yeah. So, so the thing is that you, in tibia it might work, because tibia has a flat articular surface, more or less. But in femur, being a curved articular surface, even if you put a iliac crust, it will not support the cartilage all around. And then your cartilage remains ping pong, it keeps moving when the patient walks, and you get an early arthritis. So if your cartilage is ping pong, you can actually press the cartilage, it is best to use cement. We have lot of experience of using cement. Just put a thin gel foam and put cement. That works the best, because cement, once it cures, it will form the same shape as the condyle. We rarely use sandwich, sir, now. We tried actually initially, but we found that putting the cement is the best. Yeah. Just a small gel foam and cement. That works best. Xenograft? I have no... I have no experience, frankly, and never use xenograft, never.
I think this session is finished. We have to another presentation by Dr. Manish sir. Sir, continue your... After these two presentations, there is an interesting part, 3D printing, then live biopsy, then megaprosthesis workshop. Just... After 3D printing, there will be lunch break.
So, next two talks are pretty much similar in terms of the approach. Okay, how do you approach a pathological fracture is the same way you will approach a spinal metastasis. As far as the investigation goes, as far as the diagnostic imaging goes. The difference comes in the management plan. Okay, so I'll be discussing the approach in the extremity metastasis in a pathological fracture, and the treatment part, spinal metastasis, I'll be discussing separately. So skeleton is the third most common site of metastatic disease, and metastatic disease is very important because it accounts for, it's not coming, sorry. Yeah, I think it should come in a second. Because metastatic bone disease accounts for 17% of the medical cost of the cancer treatment in US. It's coming here, not coming there. Any idea? Why? It's coming there. Yeah, it's come. Great. And metastatic disease accounts for the 1/6 of the medical cost of the cancer treatment in US. The questions, relevant questions in pathological fracture is, first is when do you suspect, then how to approach, then the treatment plan, orthopedic management, role of bisphosphonates or denosumab, exercise prescription and rehab, and outcome. It's very difficult for me to cover all this in 10 minutes. I'll try my level best. Question is, when do you suspect? So this is simple NCCN guideline. NCCN is National Comprehensive Cancer Network by US. Any symptomatic bone lesion with an abnormal radiograph, less than 40 years, we suspect primary bone tumor and refer to orthopedic oncologist. More than 40 years, we work up for potential bone metastasis. So any lytic lesion or a symptomatic bone lesion in a patient more than 40 years, you have to work up thinking that it's a potential bone metastasis. And any history of pain before a fracture or fracture after a trivial trauma is highly suspicious of a pathological fracture. So always take that relevant history. In fact, chance that a solitary bone lesion in a patient more than 40 years is metastatic carcinoma is 500 times more common than a primary bone sarcoma. So you need not evaluate them as a primary bone tumor in more than 40 years, because most of them will be a primary bone metastatic carcinoma. Second question comes, how to approach? The approach is straightforward. We focus on history, some tumor markers and radiological investigations. In a previous asymptomatic patient who presents with a pathological fracture to you, lung, kidney, prostate and breast as the most common sites. With previous history of cancer, GI tract, head, neck, prostate and breast are the common sites. You need to take the other histories like symptoms of visceral disease and organ dysfunction and any other comorbidities. Examination, do a performance status, identify all painful sites, see neurology, and identify signs of other organ dysfunction like primary malignancies, like a breast lump, abdominal lump, any liver enlargement or etc. These are the lab investigations that we order in the initial go, which is calcium, immunoglobulins, PSA, tumor markers, which is CEA and CA 19.9 and ESR. And there are 6 good reasons not to undergo for a biopsy of the lesion first, even if patient presents with you with a pathological fracture or a lytic lesion. It could be myeloma and biopsy is not needed. So even 99% of myeloma you can diagnose only on blood test. You just need a serum immunoelectrophoresis with immunofixation and serum free light chain assays. If both are normal, then 99% you have ruled out a myeloma. So just order these 2 investigations, SIEP with immunofixation and serum free light chain assay, and myeloma is ruled out. It could be a primary bone sarcoma and requires a better planning, so don't go with a biopsy first, do an MRI. It could be a vascular neoplasm, as I have shown you in my previous presentation. You can cause a catastrophic bleeding. You might find a more accessible site for biopsy. This is very important, because if patient presents to me with a lytic femoral lesion and I do biopsy from that and it turns out to be a metastatic carcinoma from lung, but nowadays lung cancer requires lot of genetic markers like a ALK mutation, ROS mutation, EGFR mutation, which has a significant therapeutic implications. Lung cancer, now patients survive for 5 years or 10 years with these mutation testings and the appropriate treatment. But bone biopsy, they cannot do a mutation testing. So you are suspecting a pathological fracture, so better to biopsy a lung rather than biopsying a bone. So better to do a imaging studies before you biopsy. So don't go and jump for a biopsy at the first go. Giving all relevant information to pathologists is vital, as I have mentioned in my biopsy talk. And if you are planning a frozen section during surgery, a working diagnosis will definitely help in a metastatic disease. So these are the investigations that you do. And there is a very good paper which was published long back in 1993, skeletal metastasis of unknown origin. And they have actually given a relative value of all these things. They had a 40 patients and history and examination diagnosed 3 of the primary sites. Labs didn't help in anything because they excluded all myeloma in their analysis. Chest radiograph helped in diagnosing 17 patients. Bone scan showed a multiple lesions in 14. Cross-sectional imaging in 11 and biopsy in 14. So overall diagnostic accuracy of this algorithm is 85% for identifying a primary site in a suspected metastasis. Just do these investigations in a sequential way and you will be able to reach the primary site. We do an MRI or the CT of the affected part only when we are suspecting a primary sarcoma, usually in less than 40 years of age. So what should be done if a patient presents with a pathological fracture? So I just told you 50 years male, path fracture, 500 times more common that it will be a metastatic cancer than a primary sarcoma. So will you do this? Because the chance that it will be a primary sarcoma is 1 in 500. 499 it will be metastatic carcinoma. So someone heard my presentation and did this. So they thought it's a metastatic carcinoma, let's nail it first, reduce the pain and then evaluate. So the final biopsy was high-grade leiomyosarcoma of bone and PET CT was non-metastatic, and ultimately patient required a total femur excision and a replacement. So even if there is 1 in 500 chance of a primary bone sarcoma, you cannot nail a pathological fracture, because once you nail, you contaminate the full medullary canal and the only way out is to resect the full bone. So what should be done if a patient presents with a pathological fracture? Answer is workup. You have to avoid a rhodid sarcoma. This is the same, and the most key thing that you can take from my presentation is do not rod a pathological fracture. Diagnose it first before you nail it or before you fix it. And with the PET CTs, we can use a PET CT quite early to diagnose or identify the primary sites. Coming to the treatment plan and the orthopedic management, this is little challenging. The treatment goals are very clear cut. We want a pain relief. We want to improve the function, which should be long lasting, more than the patient's life. But for that, we should know the 6-month survival rates. Prostate will survive, 98% chance prostate will survive for 6 months. Breast will survive 90% of cases.